Hello, Don here. Welcome to Podiatry Practice Mastery, where I'm kind of sharing the things that are working in my practice to get to the $1 million mark and beyond. Hopefully, this will give you some inspiration for your practice. So today, I'm recording a day of Tuesday in the practice. It was a full day, so we'll kind of get into this. So first patient, she is a 28-year-old female. She was one that had kind of failed terbinafine, she failed diflucan, and now she is on itraconazole. She is doing well. She has some proximal nail clearing finally, and I sometimes don't understand why one doesn't work and the other, but that's why I have those three that I kind of go through kind of in that order. She's getting better. The nail looked a little bit thick. I ground it down. I don't normally grind down nails, but in her case I did grind them down, and they look a little bit clearer kind of at the base of the nail. So that was that patient. Next patient was a 48-year-old female. She had a bilateral KeryFlex with my nail tech. So one of her nails detached. So she has only maybe one, I don't know, a small little piece at the base to attach to. So there's not much nail because of a previous procedure by someone else. And she comes in every couple of months for this and to get it reapplied because she likes the way they look. I find if there really isn't much nail at all, you can't make the nails that long with the KeryFlex, and it's so nice having Marjorie do that for her. She also, when I was there talking to her, she also had orthotics in the past, and she requested a pair of orthotics. Now this patient, her KeryFlex did fall off, so usually if the KeryFlex falls off, I don't charge them the full application fee a second time, like a month later, because it gets kind of expensive. So I tend to guarantee them. This is kind of the way I do it. I guarantee them for 3 months. If it falls off, I put it on for only an office visit, or Marjorie put it on and we did an office visit. We also got orthotics, and she bought the kit that went with it. Next patient was a 68-year-old female. She had an x-ray, she had an ultrasound, and she had pain in the second metatarsal. Had a bursa underneath the second metatarsal head that was painful for her. So we did a cortisone on the plantar bursal region with an ultrasound. Now she has that second hammer toe that's kind of going up and over and a little bit dislocated, and so we did talk to her about relocating that. But it's going to be maybe pinning, but maybe a plantar plate repair for that patient. Next patient was a 59-year-old female, number 3 out of 4 for Swift. Next patient, I do 3 out of 4 just so you guys know how many I tend to do, so how many they have set up. The next patient was a 63-year-old man for nail fungus. He decided not to do the nail sample. He just wanted to get right into it, and so we did a 3-month follow-up and prescribed the terbinafine. I looked at his LFTs. He showed it to me on his phone. He had a little app that I could look at his LFTs from his doctor. Next patient was a patient that had X-rays. She had some nails and calluses, and she had a hammer toe on the left 4th digit, and that was kind of bothering her. So we looked at that for her, and this is one that kind of a challenge when you get these. You probably all get these, but this is a patient that said, "Hey, this other doctor, he moved his office, and his nail care is always covered by him, so I want to make sure it's covered by you." And I never guarantee that for patients. I say I'm too young in my career to make things up. So I said, if it's not covered, we charge $75. I think we're low. I think I'm going up to $100. I'd like to know what other people do, but if it's not covered, but it's $75 currently. We evaluated the digit. I did the nail care, and then we'll see if it's covered by insurance. I doubt it. I don't think she has class findings. Next was a 21-year-old female. She's here for a follow-up for cellulitis after a nail puncture wound. The cellulitis is getting much better. She still has some guarding, I think, due to the puncture into the tissue, and things are still painful in there. She's still guarded, but feeling quite a bit better. Next patient was a 58-year-old female. She has really a neuropathic foot with Charcot, and I had her go to Hanger to get a Crow boot, and we did an x-ray afterwards. So she's doing better in the Crow for 3 months. I'm going to keep her in for another 3 months and then transition her into a diabetic shoe. The next patient was a follow-up after 6 EPAT. 69-year-old female. She is doing great. Has no issues. She had a little issue with her orthotic being like a rubbing a little bit on the lateral side of the heel, so I heated them up and dropped down the lateral side a little bit. And she's feeling much better. This is when I did a video on, so I'm starting to do YouTube shorts, or I use Submagic, and I record them right in the treatment room for like successful patients, or like certain videos that I want specifically for our website. So a couple of things we've been doing lately. I do have a virtual assistant that helps on the website, and she's doing some like focused web pages on things that I want, like orthotics. And so when I get a good orthotic or shockwave success story, then I will make a short, and then I can put that on the website. So the way I do that is when I record it, it automatically uploads it to Submagic, and then I'll rename it to say like, hey, this is a good one for the page on orthotics or the page on shockwave. And then when the virtual assistant goes in there and they add the subtitles and the title and they upload it, they'll know to upload it as well on the YouTube. It's the YouTube and also on the website in that area. So it kind of has a workflow pattern, and it allows me to make the videos without two problems. One is it doesn't occupy space on my phone because it uploads it directly to their platform called Submagic. I do it right from my phone. And the second thing is it allows me to do it in the treatment room with the patient versus having to wait or record it at another time. I find getting it done right when I'm with the patient works better. Next patient was a 58-year-old female. She had first metatarsal, kind of the plantar medial aspects, like a neuritis. So we did x-ray, recommended some things for that. Recommended like a cortisone. She didn't want that, but just said I would give it time. I think it was a bad shoe that kind of aggravated it. Next was a swift 3 out of 4, getting better. Next was a 5th met base fracture. Got an x-ray, doing much better. No follow-up. They're within the global period. Next was a 82-year-old that came in for an office visit, and he had a porokeratoma on the or IPK on the right 5th met head, so I removed that. Next was a 41-year-old female that EPAT status post 6 sessions, 6 weeks out. She felt like her orthotics set her back. They're kind of a high arched orthotic, and I tried to lower them down in the office by heating them up, but they may have been a little bit too high. So what I did is I said, if it continues to bother you, I'm going to drop down the arch for you. I don't charge if I do that. And I did another shockwave for her, just because I wanted her to get better, and she's already paid for 6. It didn't really take much extra time for me, so I did another shockwave on her, just the soft wave only for her. She was doing better. I did another ultrasound as well for her. That did still show thickening and effusion within the plantar fascia, so might just need more time or a few more treatments. Next was an 82-year-old man. He had a right ankle sprain. He had a little fall, and he had a follow-up on his nail fungus. He's been taking terbinafine as well. He's doing well. Next was a 65-year-old female that had pain and foot swelling. I recommended an AFO because she had some posterior tibial tendinitis. She wanted to try her orthotic first. She has an older orthotic she hasn't been wearing, so I gave mostly shoe recommendations for that. Next was a 43-year-old that had she's here 4 weeks out for a medial cuneiform fracture, which is quite odd. And I'm going to order an MRI because she's not feeling much better, and I just want to make sure I'm not missing anything, so I ordered an MRI for her. Next was a patient with an IPJ hallux ulcer. Getting better. We struggled with him with his insurance in terms of covering collagen. So for him, he actually went to Amazon and found like collagen powder for $30. I don't know if it's the same stuff as I do with the Amerigel, but it certainly is a lot less expensive. That's what he got, and he felt like it worked last time for him to get it healed. But I think a lot of it has to do with his hallux limitus and his biomechanics. Next was a 61-year-old male, got an orthotics, bilateral. Oh, this guy's a butcher. So he's a butcher. He's on his feet a lot. Came in many years ago for plantar fasciitis. And what I found is, certainly even though I have a new treatment, which is shockwave, patients tend to want what worked last time, and I tend to try that first. So I learned this at a lecture about like surgeries, right? If you do an Austin on one patient and it worked really well, they're going to want an Austin on the other side. Even though a Lapidus might be preferred, a lot of times they just know what to expect and they kind of want the same thing. So same thing with orthotics. He had Northwest, so I scanned him for Northwest, even though I don't use that as much anymore. I scanned him for Northwest. And he had bilateral cortisone last time that worked, so I did bilateral cortisone. He also had orthotics, so I made new orthotics because his current ones are cracked. And then I also added on there bilateral night splints for him. So we got bilateral ultrasound, bilateral x-ray, night splints, orthotics, and the cortisone. So this is an idea of kind of like stacking up treatments that can be beneficial for our patients. Next was a patient, 6 out of 6 had a shockwave, and I did an office visit, and they'll be back in 3 months, actually 6 weeks for the follow-up. Next was a 76-year-old that had an IND for ingrown toenail and nail care. Next was a patient, 59-year-old female, that had bilateral subtalar joint pain, so I did bilateral sinus tarsi injections. No ultrasound guidance for that because it's kind of a bigger joint. And then finally there was a patient that had some kind of weird kind of foot numbness and pain, and I did gabapentin for this patient. And I'm going to see them back in 3 months and see how they're doing. So that was the day. I did do a couple of videos. I try to do a couple of videos every day. So the thought is there's going to be... and then what my virtual assistant does is they batch those videos. Another benefit I like to doing shorts is I don't have to do thumbnails. So it saves a little bit of time on thumbnails. And the idea is the best producing videos, then you can turn those into like ads by putting a little call to action at the end of them. This is something I learned from Alex Harmozy for marketing. Okay, guys. Until next time, have a good one.